Most students make the mistake of thinking that once they've done an algorithm or they've walked through a table, that they're done with their learning. That is really a bad idea, because I'm here to tell you that's only the start of the discussion. The question isn't what you know. The question is, why do you need to know it in patient care? I'm going to demonstrate a really powerful algorithm on how to think about liver. But what I'm then going to do, having shown you the algorithm, I'm going to show you how it's really not very helpful if you don't understand how to think about it in clinical care, connecting to the basic sciences. If you're a medical student and you want to take all that memorized material and reformat it so you use it in clinical care and for clinical vignette exams, be sure to subscribe. I'm Dr. Philip Tisdall. I practiced clinical general pathology for decades, developed a deep interest in teaching medical students, and I've been doing that for over a decade now. I want to show you how I think about liver. This is a really good way to organize the whole organ. And we start with the commonest presentation of liver disease, which is going to be jaundice. But that just gives us a comfortable place to start that we all recognize with yellow eyes. Think of this as how I think about liver. And when you do, the first thing you've got to do, and the rule of algorithms is, don't miss the first step, is you've got to decide if you have greater than 80% unconjugated bilirubin. Because if you do, we're going to take that aside. That's its own separate idea, because we're going to see that with Gilbert's disease and with hemolysis. Once we've taken those two off causes of jaundice, now we can break our discussion into, is it cholestatic, meaning is it in the biliary tree, or is it hepatitic? Is it a disease of the hepatocyte? That's our fundamental division in liver, and it works really great. Now, there's a little structure function here, and watch how fast I can do this. When I say cholestasis, meaning an inability to make bile, I'm in the biliary tree. What do you think of when you say that? Because this is what I think of, and it works really well. I think of this. There's the when I say biliary tree, it should be that. Because what that lets us do is it lets us break it into our intrahepatic and extrahepatic. So if I go through and say, can you name all the parts? There's my left hepatic, common hepatic, cystic duct of the gallbladder, common bile duct, pancreatic duct, and in any tubal system, you always want to know the narrow spot, and that's my ampulla vater because it has the sphincter vadi. So how are we going to know if it's hepatitic or cholestatic? And this is where we basically use our liver function testing. If it is an elevated alkaline phosphatase, it is cholestatic. If it is an increase in ALT, it is hepatitic. And it's that straightforward. If I say cholestatic, then our decision has to be, is it intrahepatic or extrahepatic? And the way we do that is we use the idea of obstruction. If I have an obstruction, everything upstream backs up and it dilates the structure. So let's take a look at our common bile duct. That's going to work really well, because if my common bile duct is greater than 1 centimeter in diameter, it's dilated. So that's going to be extrahepatic. But if my common duct is not dilated, meaning it's less than 1 centimeter, that's going to be intrahepatic. And I'm just going to keep this brief because this is a demonstration lecture. But when I say extrahepatic, we're kind of only talking about two diseases that medical students have to know. We're either talking about a gallstone, so this is going to be our standard 4Fs patient, or it's going to be a cancer of the head of the pancreas, so that's going to be a 67-year-old smoker. If I say intrahepatic, for the medical student, just in this brief discussion, it's going to be one of two things. You're going to do the antimitochondrial antibody, and it's either going to be positive or it's going to be negative. If it's positive, this is going to be primary biliary cholangitis, and if it's not, it's a whole long list we're not going into today. Great. Let's go over and talk about our hepatitic. And this is based on my practice. So this isn't a logic tree. This is basically a prevalence tree. So if your practice is different, you might do this differently. When I ask if it's hepatic, I ask, what is my AST to ALT ratio? If it is greater than 2, that's going to be ethanol. If it is less than 2, it's not. Then we're going to start breaking it out. And again, this is prevalence-based. The next thing I want to do is I'm going to ask, is it viral? So now we got to do the hepatitis virus testing. If it's not viral, it's going to be the list. And this is a great list for medical students because it tells you all the diseases that you need to know. So let's just go through them. It's going to be autoimmune hepatitis, Wilson's disease, copper, hemochromatosis. That's going to be iron, drugs. Lots of medications can do this. And then last on the list is going to be our what we all learned as non-alcoholic fatty liver disease, but is now metabolic dysfunction-associated steatotic liver disease. Good luck with that. I've shown you how to think about liver as hepatic cholestatic, but don't miss the unconjugated hyperbilirubinemia. If you got that out of our demonstration of the algorithm, that's a really good place to be. What I now want to show you is that actually isn't the end of our learning. That's the beginning of our learning. Over the years of teaching, I've been completely convinced that you cannot teach yourself medicine. I think medicine requires deep tutoring in small group sessions. So now that you've done the algorithm, I'm now going to show you what it feels like to have a tutor. We're going to start with the idea of jaundice. And so here's where I would start as a medical student. I would say, if I have a patient with jaundice in my office, no testing, how would I differentiate hemolysis from acute hepatitis from a virus? How would you do that differential? You actually don't need lab testing to do it. And what that would say is, can you do bilirubin metabolism? Because if you can do that, this is what it's going to look like. We're going to say, is the patient jaundiced? What is the urine? What is the stool? And what is the urine urobilinogen? Right? All you've done is the algorithm. We didn't even start with the algorithm, did we? We started with this teaching idea of walk me through hemolysis versus acute viral. So if you have hemolysis, and this is now greater than 80% unconjugated, it doesn't matter. Bilirubin's bilirubin, you're still jaundiced. But what you're going to notice is urine is normal, stool is normal, but you're going to see an increase in urine urobilinogen. What would we see in acute viral hepatitis? That's going to be quite different. If it is hepatitis, jaundice is jaundice, so the fact that it's a mixed bilirubinemia won't change. Urine will now be brown and foamy. Your stool will be pale and chalky, and there'll be no measurable increase in urobilinogen. So most of the time when I'm teaching students, we never actually get further down the algorithm because we first have to walk through bilirubin. There's the start of tutoring. The next place I'm going to go is tell me about why we use ALT as our basic, fundamental, excellent test of liver damage. So now you have to tell me, what is ALT? It is alanine transferase. Okay, great. Why do we use that in liver? And the answer is because it is a central enzyme in gluconeogenesis. Yep, now we get to stop and do biochemistry. But just as a quick reminder, tell me about gluconeogenesis. The answer is we highly preserve glucose in the blood. Can you tell me why? And the answer is because there are two critical cells that only use glucose. So that's going to be our central nervous system and our red cells. And so it's highly preserved. When glucose drops, then we're going to go into fatty acid metabolism, lipolysis, glyconeogenesis, and gluconeogenesis. So when I say to you 24 to 48 hours of fasting, we're going to start gluconeogenesis. And your muscle cells are going to mobilize muscle proteins and release into the blood our alanine. And that's going to be picked up by our liver. And in the liver, alanine is going to be converted to pyruvate. And the enzyme that does that is ALT. And gluconeogenesis is so overwhelmingly hepatic in origin that it becomes a specific marker of liver. Anytime you have liver disease and a breakdown of hepatocytes, ALT will be released into the cytosol and show up in the blood. It's a very specific and very sensitive marker. So if your ALT is normal, it's unlikely that you have specific disease. Okay, that makes really good sense. That's why it's always universally an ALT marker. But why is the AST-ALT ratio useful? Well, let's talk about AST. AST is not a specific enzyme. It's about 20% in the hepatic cytosol and about 80% in the mitochondria. And it basically is an amino transfer. So in the cytosol, it moves the amine around between synthesizing various amino acids, so it has a general purpose. In the mitochondria, it actually has a much more specific purpose that's really related to our TCA cycle and NADH metabolism. But here's what's significant. When I say to you, tell me diseases that are specific to the mitochondria, I'm going to say to you alcohol, acetaminophen, and ischemia. Okay, why? Because when I metabolize ethanol, remember it is a multi-phase process. So I'm going to convert my alcohol to acetaldehyde, and acetaldehyde is going to go into my mitochondria where the dehydrogenase will take it to acetate. So I get high levels of acetaldehyde in the mitochondria. As well, alcohol produces reactive oxygen species. So alcohol actually is quite toxic to mitochondria, where I find the AST. So alcohol is related to mitochondria, and therefore it disproportionately elevates AST. Well, what happens in acetaminophen? It also applies to alcohol to some degree. Remember that acetaminophen has two metabolite processes. It happens in the cytosol where we get our conjugation, but also remember there's a pathway in the mitochondria that's on our CYP2E1, same as with alcohol. And this is the central enzyme that's going to make the toxic product of our acetaminophen, which is NAPQI. Well, yeah, that's really toxic to the mitochondria. Remember as well, we get glutathione depletion, so we're also going to get a reactive oxygen species. I know this isn't in the mitochondria, but our microsomes are by the mitochondria, and so we see this NAPQI toxicity. Well, what about ischemia? Well, we're not going to go into it right now, but can you tell me the three most important patterns of cell death? Because one of them is going to be our MPT-driven cell death. And if you haven't got that, well, then we would stop at this point and talk about our molecular cell death. But part of the essential step of it is an influx of calcium into the mitochondria allows the mitochondria to release cyclophilin D1, and we get our inner mitochondrial pore that leads to cell death. So all of a sudden, this feels like a longer, deeper connected discussion, doesn't it? Well, tell me about alkaline phosphatase. Alkaline phosphatase is only found in the biliary tree. So it's a pretty good marker in the liver for biliary tree versus hepatic. The problem is it's also found in bone and muscle and other organs. So your ALK phos is a really great selective protein for liver hepatic cholestatic. The problem is anytime you get activation of our osteoblasts, and you can see we can go alongside discussion here, we're also going to see it elevated. They are the same isoenzymes, so even fractioning out the isoenzymes doesn't solve the problem. Now, most of the time it isn't an issue. You know if it's bone or liver. But if you didn't, then you're going to bring in a deciding enzyme, which is called gamma-glutamyl transferase. And this is related to glutathione. I can't imagine anyone would ask you this, but it recycles the cysteine of glutathione synthesis. But GGT is specific to the biliary tree, so this becomes a very helpful way of sorting out what your ALK phos is from. Now, you might ask, why don't we just do GGT all the time then? And the answer is, ALK phos is an easier test to do. It's historic, it's set up on all machines, and it works really well generally. So this becomes a second-order test. Now, note there's one difference here than when we talk about our ALT. ALT is a cytosol enzyme that's released into the interstitium when the cell dies and dissolves. Alkaline phosphatase is not. It is induced, which means when you have whatever the insult is to the biliary tree, it's not going to increase until at least 24 to 48 hours because it has to be actually upregulated. So in that sense, they have a little bit different time lag. So you can see we've just done the top half of this discussion. If we were going to continue the discussion, you could see what we're going to do is I would then take you and say, tell me about alcohol effects on the liver. I would then expand this into, let's go through how do you think about the viral hepatitis? And I would tell you, I only think about them as A, B, C. I don't do D because it requires B, and I don't do E because it requires travel, which is self-evident. And then it really becomes valuable to a medical student when I say, walk me through autoimmune hepatitis. Because can you do type 1 and type 2? Because they have different antibody profiles. Our type 1 is liver, kidney, microsomal, because it's going to be looking for a specific protein in the cytosol, which is one of the CYP enzymes. And I'm not going to bring it up today because I certainly don't want you to know it. But the second pattern, the more common in adults, is going to be anti-smooth muscle antibodies. And this is to an element of the proteins of smooth muscle, which is going to be actin. In Wilson's disease, we get to talk about copper metabolism, talk about hemochromatosis. Can you do hepcidin and the ferroportin connection? And then in our, as all of us are stuck on, non-alcoholic fatty liver disease, we have to talk about what that disease is going to be like and how it evolves into fibrosis. So I'm going to stop there. I want you to see this idea that learning gives you enough knowledge that then tutoring can give you this deeper insight connecting to other processes and ways of thinking about the disease. You can see this could be a very long discussion. Normally it takes me at least a morning to go through this. But I wanted you to have a sample of what it feels like. And obviously, if I was in person, we would be interacting. So that would lead to many other side discussions of ideas that you need to know to have depth in understanding as you're going to apply it through exams and clinical medicine. If you haven't got the textbook yet, that is the foundation of everything that we're teaching in pathophysiology. Click the link in the description. See you next time.